Thank you, Matteo. Just get oriented here. So I think we have a lot of exciting information the rest of the conference. I'm going to just comment on a few things. These are my disclosures. I think one of the challenges that we face, even though progress has been somewhat slow in developing therapies, is that we really have an imperative because of the shift in demographics in the world, in the United States. I mean, the fastest growing segment of the older population right now are individuals over the age of 85 years. And this is going to lead to an inevitable increase in functional limitations, disability, and frailty. And I think it's worth, when we talk about the cost of therapies, it's worth reflecting on the cost of mobility disability. These are data from Susan Hardy using Medicare data, but just showing the total cost stratified by people's self-reported ability to walk a quarter of a mile, showing that the cost to the healthcare system is great for people that have difficulty or are unable to walk something as short as a quarter of a mile. And I can see that these costs will only rise. So although we have challenges in developing therapies and increasing awareness about potential for intervening here, I think there is an imperative both from an economic standpoint and from a patient and quality of life standpoint. Now, like many geriatric syndromes, sarcopenia is complex, has multiple origins and additional origins that we're learning about, like life course trajectories and fetal programming, which was so eloquently described in our first keynote address. But I think this does pose a number of challenges, both from a targeting perspective and also from a clinical trial and intervention perspective, because multiple things may impact the plasticity of skeletal muscle mass and function. So while we may intervene in one area, we have to also be aware of other factors that are going to contribute to changes in muscle function in intervention trials. Now we've known, and there'll be lots of presentations about the number of clinical trials, both using lifestyle and pharmacologic interventions. I think where we've seen a lot of data reported recently in pharma trials have been with the selective androgen receptor modulators, the anti-myostatins, some growth hormone secretagogues. In other neuromuscular diseases and conditions, there have been trials, or early trials, looking at modulators of either neuromuscular activation or contractile function. We've yet to see any interventions looking at inducers of mitochondrial biogenesis, and certainly drugs that are currently approved for other indications have been studied, including testosterone, and also further discussions about a need to look at multimodal interventions. One of the things that I think we have to creatively think about is really what other potential targets in muscle might be amenable to treatment and intervention, because while these studies have been done and they're very early, we haven't seen something that has had very, very strong efficacy and strong sort of success in terms of leading to perhaps a phase 3 trial. As I mentioned, I think drugs approved for other indications are important. And this issue about combining treatments and looking at situations in older patients where they're already actively undergoing rehabilitation, either after injury, surgery, or fracture, may be an area where first indications might occur. And I think that still needs to be vigorously pursued. We are aware of a number of challenges in developing therapies in this area. I think the prominent one is really the lack of an objective definition of sarcopenia that's linked to hard endpoints. I know Cyrus mentioned this, things like mortality, falls, and fractures, because I think that's the evidence that's going to be necessary to continue and to go forward. We still are struggling and debating about appropriate outcomes, the effect size of those appropriate outcomes, whether it's effect size or minimally clinically important difference to use for efficacy and ultimately registration trials. We now have an initial establishment of an ICD-10 code, and I think that's, as I mentioned before, a really important milestone. But I think there is a need to think about it and think creatively about other potential targeted therapies. I think things like activators or modulators of mitochondrial biogenesis, other mechanisms by which contractile function may improve, modulating neuromuscular junction function or excitation contraction coupling. And there's this overwhelming suggestion that inflammatory burden in aging has effects on numerous tissues, including muscle and mobility. And I think that has not really been pursued and explored in any substantive way in terms of intervention trials. And I think those are areas that we should think about and move forward with, instead of trying to continue to modulate or trying to intervene on muscle mass per se. While there's some agreement among the consensus definitions, the original ones were consensus, and we have strong evidence-based definition now from the FNIH project. And what's happened, and Cyrus showed this, and I think this is an approach that's important. There have now been studies that have looked at the relative risk using these different definitions for hard outcomes like falls and fractures. This is some data that Bestos and Hughes and Heike Bishop-Ferrari reported, looking at the relative risk of falling from the Stop It trial using the various available consensus and evidence-based definitions here, and showing at least that for some of these cut points and definitions, there is an increased relative risk of falls. Certainly, this is a small analysis, and we need these kind of analyses to be undertaken in much larger studies to really understand whether lean mass or lean mass coupled with some functional endpoint is really associated with these hard, important outcomes that we've been talking about. We still have a lot of discussion and debate about what the appropriate outcomes in clinical trials are in this area. Things related to validity, sensitivity, ceiling and floor effects of performance tests, and then important things related to logistics and cost in multi-center trials. Many times we see strong effects on performance in single-site trials that are diminished when we look at 8, 10, 20 clinical sites, and the variability just increases precipitously. So I think while these tests can be simple to perform, standardizing them can be challenging and may have an effect on the outcome. I think the idea here is that if we go back to the Nagy model, we're really targeting active pathology in muscle and neuromuscular functioning here, with the hope ultimately of affecting role disability down here. But this concept and this construct is very difficult to measure and assess in clinical trials. And so we're left with looking at more intermediate outcomes like functional limitations such as gait speed and chair rise time. These are really measures of capacity or what a person can do rather than what they actually do perform, how they actually perform in their own environment. I like to think of these, some people don't like this term, but I like to think of these measures as really biomarkers of disability, and they're very sensitive, specific, and responsive to change, and I think that they can be used in clinical trials successfully. The other challenge is that the complexity, cost, and sample size of these trials really increases as we proceed more distally along this pathway. So if we're really targeting functional limitations, or even in fact trying to understand disability or performance in the environment, we're talking about very large trials. I think clinical trials in sarcopenia really need to look at outcomes that are related to physical functioning, and again, because I think physical functioning is a valid measure and is a real biomarker of real role disability in the community. And we know now from some anchor-based data that's been generated, we have MCIDs for many of these tests: the 400-meter walk, the 6-minute walk, the short physical performance battery, and the stair climbing task. So these can be used in clinical trials. They're highly reliable. There are anchor-based MCIDs, and they have been shown to be sensitive to change. The challenge is, again, with the relationship with sarcopenia to potential hard clinical outcomes. Things like mobility disability. There's some approaches to dichotomize performance tests to assess this: fractures, recurrent falls, mortality, hospitalizations, activities of daily living, or self-reported quality of life. One approach that was used in the LIFE trial was to dichotomize the 400-meter walk test to look at major mobility disability as defined as the inability to walk 400 meters. So rather than looking at speed or time, or gait speed or time to complete 400 meters, really assess when participants develop the inability to walk 400 meters as a dichotomous hard outcome in clinical trials. And with an exercise or physical activity intervention, this was in over 1,600 older adults with low physical performance at baseline, we were able to look at the effect of physical activity compared to health education here. And I just proposed this as a possible valid outcome in clinical trials. And while this study was conducted, the longest length of follow-up was 3.5 years, which is prohibitive, I think, from a cost standpoint for many pharma trials. Many of the events sort of dichotomized here very early in the trial. So it is conceivable that using an outcome like this, with an effect size like this, you can see differences and changes in as early as 6 months to a year. And this may be a valid approach. I think progress is slow, but I think it's moving in a positive direction. We've seen many interesting already new developments in this area. I think awareness and acceptance of sarcopenia as a syndrome, or if you want to call it a disease, has lagged. I think there's efforts that were presented today already that will help move this forward. I think being able to objectively link some measure of mass or function to more hard endpoints like mortality and falls in large epidemiological cohorts is really going to strengthen the area. I still think we need agreement, universal agreement on appropriate outcomes for efficacy and registration trials, and hope to see that there will be establishment of treatment guidelines and billing codes that are associated now with this newly established ICD-10 code. I think the treatments are emerging here, but the indications are lagging, and I think more work is really clearly needed. So thank you all very much for your attention. I'm happy to take any questions.